we discuss the topic biomechanics of the human lower extremity. Structure of the hip joint. Hip joint is a ball and socket joint where the head of the femur articulates with the concave acetabulum. The ball is the head of the femur, which forms 2/3 of a sphere, while the socket is the concave acetabulum, which is angled obliquely in an anterior, lateral, and an inferior direction. Hip joint is more stable than the shoulder joint because of the bone structure and the number and strength of the muscles and ligaments crossing the joint. Joint cartilage covers both the articulating surfaces of the hip joint. The cartilage on the acetabulum is thicker around its periphery, which it merges with the rim or labrum of fibrocartilage that contribute to the stability of the joint. This is the hip joint. Hip joint's ligaments. Several large or strong ligaments also contribute to stability of the hip, which includes iliofemoral ligament, which is Y-shaped, extremely strong ligament and provide anterior stability, while the pubofemoral ligament strengthen the joint capsule and provide anterior stability. Iliofemoral ligament provides posterior stability. Tension in these major ligaments act to twist the head of the femur into the acetabulum during hip extension, as when a person moves from a sitting to a standing position. Ligamentum teres supplies a direct attachment from the rim of the acetabulum to the head of the femur. These are the ligaments. Bursa of the hip joint. Several bursas are present in the surrounding tissues to assist with lubrication. The most prominent are the Iliopsoas bursa and the deep trochanteric bursa. Iliopsoas bursa positioned between the iliopsoas and the articular capsule, while the deep trochanteric bursa positioned between the greater trochanter of the femur and the gluteus maximus muscle at the side of its attachment to the iliotibial tract. These bursas assist in lubrication and decrease friction between these structures. These are the muscles and the bursas. Femoral neck. As we know, femur is a long and strong bone and most weight-bearing bone of the body, but its most weakest structure is femoral neck. During walk in single leg sport, it moves medially to support the center of gravity of the body. The femoral neck provides us two angles. First one is angle of inclination is in the frontal plane, while the other is angle of antivariation is in transverse plane. Angle of inclination. This angle formed by the meeting of axes of the shaft of the femur with the long axis of the femoral neck and the head. An increased angle is called coxa varus and a decreased angle called coxa valgus. The normal angle is approximately about 125 degree, which vary from 90 degree to 135 degree. Angle of inclination affect lever arm. This is the angle of inclination. Normal angle is about 125 degree. In coxa vara, it is decreased from 125 degree, and in coxa valga, it is greater than 125 degree. Angle of antivariation. The angle of antivariation is composed by the intersection of the long axis of femoral head and the transverse axis of the femoral condyle. This angle averages approximately 12 degree in adults. If the angle is greater than 12 degree, it means that head of the femur is in antivariation, which means internal rotation on leg or toeing in. If the angle is less than 12 degree, then it means that head of the femur is backward or in retrovariation, or the legs are in toeing out. This abnormal angle increases stress on the hip joint and affect gait. This shows toe in and out during antivariation and retrovariation. Kinematics. Hip motions take place in all three planes, like in sagittal plane, flexion and extension movement present, in frontal, abduction and adduction movement, in transverse, internal and external rotation movements present. range of motion in all three planes, movements at the hip joint. The pelvic girdle includes two ilia and the sacrum. It can be rotated forward, backward, and laterally to optimize positioning of the hip joint. What movements of the femur are facilitated by the pelvic tilt? The pelvic tilt facilitates movement of the femur by rotating so that the acetabulum is positioned toward the direction of impending femoral movement. For example, posterior pelvic tilt with the anterior spherical spine tilted backward with respect to the acetabulum position the head of the femur in front of the hip bone to enable ease of flexion. Likewise, anterior pelvic tilt promotes femoral extension, and lateral pelvic tilt toward the opposite side facilitate lateral movements of the femur. In simple words, posterior pelvic tilt facilitate flexion of femur, anterior pelvic tilt facilitate extension movement, and lateral movement of pelvic is facilitate abduction movement of the femur. What muscles contribute to flexion at the hip joint? There are 6 muscles primarily responsible for flexion at the hip are those crossing the joint anteriorly. It includes psoas major, iliacus, pectineus, rectus femoris, sartorius, and tensor fascia lata. These are the muscles. Rectus femoris muscle is a two joint muscle which is active during both hip flexion and knee extension. Its function more effective as a hip flexors when the knee is in flexion. The thin strap-like sartorius or talus muscle is also a two-joint muscle which crossing from the interior iliac spine to the medial tibia just below the tuberosity. The sartorius is the longest muscle of the body. What muscles contribute to extension at the hip joint? The hip extensors are the gluteus maximus and the 3 hamstring muscles which are biceps femoris, semitendinosus and semimembranosus muscles. The gluteus maximus muscle is a massive, powerful muscle that is usually active only when the hip is in flexion, as during stair climbing or cycling or when extension at the hip is resisted. These two joint muscles contribute to both extension at the hip joint and flexion at the hip joint and active during standing, walking, and running. These allow extension at the hip and flexion at the knee joint. What muscles producing abduction at the hip joint? The gluteus medius is the major abductor acting at the hip with the gluteus minimus assisting. These muscles stabilize the pelvis during the sport phase of walking and running and when an individual stands on one leg. For example, when the body weight is supported by the right foot during walking, the right hip abductors contract isometrically and eccentrically to prevent the left side of the pelvis from being pulled downward by the weight of the swinging left leg. As shown in this picture, if the gluteus medius muscles are weak, the pelvis of the other side is dropped. Movement at the hip. What muscles contribute to adduction at the hip joint? The hip adductors are those muscles that cross the joint medially and include the adductor magnus, adductor longus, adductor brevis, and gracilis muscles. The gracilis muscle is a long, relatively weak strap muscle that also contributes to flexion of the leg at the knee joint. The other 3 adductor muscles also contribute to flexion and lateral rotation at the hip, particularly when the femur is medially rotated. The hip abductors are regularly active during the swing phase of the gait cycle to bring the foot beneath the body center of gravity for placement during the sport phase. What muscles contribute to lateral rotation at the hip joint? These include piriformis, gemellus superioris, gemellus inferior, obturator internal, obturator externus, and quadratus femoris muscle. What muscles contribute to medial rotation at the hip joint? The medial rotators are weak muscles in comparison to the lateral rotator, with the estimated strength of the medial rotators are only approximately one-third that of the lateral rotators. It includes gluteus minimus, tensor fascia lata, semimembranosus, semitendinosus, and gluteus medius muscles. Loads on the hip joint. Hip joint is well designed to bear the large load it habitually sustains. Because the diameter of the humeral head is somewhat larger than the articulating surfaces of the acetabulum, contact between the two bones during initiation of weight bearing begins around the periphery. As loading increases, the contact area at the joint also increases, such that stress level remain approximately constant. Compressive forces due to the following: during swing phase of walking, an amount of load more than 0.5% of the body weight and above hip, and tension in surrounding muscles. It means that when body weight is evenly distributed across both legs during upright standing, the weight spotted at each hip is 1/2 of the weight of the body segments above the hip, or about 1/3 of total body weight. However, the total load on each hip in this situation is greater than the weight spotted. Effect of sweat is vary according to footwear, training surfaces, or painful condition. Because tension in the large, strong hip muscles further adds to compression at the joint, because of muscle tension, compression on the hip joint is approximately the same as body weight during the swing phase of walking. Common injuries of the hip joint. Fractures are the more common in hip injuries. The pelvis and the femur are large, strong bones. The hip is subjected to high repeated loads during weight bearing phase. Fracture of femoral neck frequently occur during the sport phase of walking among elderly individuals with osteoporosis, which is a condition that reduces bone mineralization and strength. These femoral neck fractures often result in loss of balance and a fall. A common misconception is that the fall always causes the fracture rather than the reverse, which may also be true. Hip fractures in the elderly are a serious health issue which increase risk of death, increasing 5 to 8-fold during the first 3 months. Regular physical activity helps protect against the risk of hip fracture. Contusions. The muscles on the anterior aspect of the thigh are in prime location for sustaining blows during participation in contact sports. The resulting internal hemorrhaging and appearance of bruises vary from mild to severe. A relatively uncommon but potentially serious complication secondary to thigh contusion is acute compartment syndrome, in which internal bleeding causes a buildup of pressure in the muscles compartment, causing compression of the nerves, blood vessels, and muscles. If it is not treated, then this can lead to tissue death due to lack of oxygenation, as the blood vessels are compared by the raised pressure within the compartment. Strain. Basically, two types of strain are more common. First is hamstring strain and second one is groin strain. Hamstring strain. It is mostly occur during daily activities that do not require simultaneous hip flexion and knee extension during late stance or late swing phase as concentric contraction present. The hamstrings are rarely stretched unless exercises are performed for that specific purpose. The resulting loss of extensibility makes the hamstring particularly susceptible to strain. Strain of these structures are most commonly occur during sprinting, particularly if the individual is fatigued or neuromuscular coordination is impaired. Groin strain. Strains to the groin area are also relatively common among athletes in sports in which the forceful thigh abduction movements may overstretch the adductor muscles. Strengthening of the hip adductors muscles can reduce the likelihood of adduction sprains. It is more common in ice hockey players. Thank you.